A personal experience with anti-aging therapies. Can nicotinamide and metformin reverse aging? An experiment of 1. The presenter and the patient are the same in this presentation. I am free to discuss aspects of treatment and effectiveness without limitation, from institutional review boards, governmental oversight, academic bias, industry or pharmaceutical patents. There's no financial gain, incentive, or compensation of any sort. The intent is purely dissemination of useful information to further discussion and research into the field of aging. An N of 1 study is not publishable, but readily discussable in the format of a YouTube presentation. None of these therapies should be initiated without the direct supervision of an experienced clinician. No medical endorsement for treatment is made. Anti-aging therapies are not recognized, nor are they approved by the FDA. Thus, any treatment of this sort would be off-label. The treatments that I initiated began in January of 2016 and continue to November of 2017. I started this treatment with no medical problems, and I currently still have no active medical problems. This intervention was only pharmacological. Nicotinamide and metformin are two of the treatments used. The medications were titrated over the course of therapy secondary to potential toxic and lethal side effects. Combination therapy was chosen to maximize any clinical benefit. Close toxicological scrutiny is mandatory. Both medications demonstrated convincing biologic plausibility, and hence that's why they were chosen. This is me, age 50, December 2015, weight 217 pounds, body mass index 34. February 2016, 1 month into therapy. April 2016, 4 months into therapy. July 2016, 7 months into therapy. December 2016, 1 year into therapy. April 2017, 16 months into therapy. June 2017, 18 months into therapy. August 2017, 20 months into therapy. October 2017, 22 months into therapy. Finally, age 52, November 2017, weight 167 pounds, body mass index 26, 23 months of therapy with a 50-pound weight loss. Comparison of December 2015 with November 2017 demonstrates age-related changes to the face have been ameliorated. Diminished global, subcutaneous, and visceral fat. The color and texture of the skin appeared more youthful and balanced. Diminished sebaceous hyperplasia and other skin growths on the face were noticeable, and there were no adverse effects on wound healing. The clinical effects were not evident until several months had passed. A peculiar aversion to glucose-containing foods developed, which altered global diet. Significant recovery of short-term, long-term, and recall memory was evident. Marked enhanced sleep quality and restorative sleep was surprising. Blood pressure well controlled throughout the entire treatment period. Significant weight loss developed. The primary loss of adiposity, but at the same time, preservation of lean body mass. This effect occurred in the absence of any exercise or caloric restriction. Average caloric intake was between 1,600 and 2,000 kilocalories per day. And as stated earlier, dietary changes were secondary to a noticeable aversion to glucose-containing foods. This effect diminished at the 18-month point. In summary, a consistent 2 pounds of weight loss per month of therapy was identified. Further, a sinus bradycardia developed after 3 months. This had no effect on performance or maximum heart rate. This particular finding excludes any sympathomimetic etiologies for weight loss. There could have been possible enhanced vagal tone, but unclear. This finding also is not described in the medical literature. This is a single lead demonstrating a sinus bradycardia, heart rate 44 beats per minute. What didn't improve or stayed the same? Well, there was no effect on age-related wrinkling. There was no effect on male pattern baldness or hair distribution. There was no effect on age-related graying of hair. There was no effect on presbyopia or age-related loss of seeing things up close. The aging process can be defined superficially as the loss of both physical and facial beauty. Age is associated with loss of symmetry, balance, and proportion to the human body. The skin sags and becomes discolored. Subcutaneous fat is lost from the facial compartment, hands, and legs. And in obesity, it is redistributed to the neck, abdomen, and thighs. Muscles become atrophic and bones become brittle. Also, hair distribution changes and graying is evident. The hallmarks of the aging process have been defined at a cellular level, and it can be defined as a decline in cellular processes across many tissues and organs with chronological age. Specifically, altered intercellular communication, genomic instability, telomere attrition, epigenetic alterations, loss of proteostasis, dysregulated nutrient sensing, mitochondrial dysfunction, cellular senescence, and stem cell exhaustion. This particular study, utilizing both metformin and nicotinamide, looks at and attempts to ameliorate dysregulated nutrient sensing, epigenetic alterations, and possibly mitochondrial dysfunction. These medications are dietary restriction mimetics. They also actively inhibit these age-related genes, one known as mTOR, another is AMPK and sirtuin, which are activated. There is crossover into epigenetics because the sirtuins are responsible for a phenomenon of deacetylation, which actually alters the DNA in your lifetime. And these particular enzyme systems also have potent anti-inflammatory effects. Metabolism and aging was first linked in the 1930s by the observation that caloric restriction, usually about 60% of the regular diet in rodents, extended both their health span and lifespan. Research has identified genes and metabolic pathways that control the aging process and control longevity. 3 classes of anti-aging genes are the sirtuins, AMPK, and mTOR. These genes elaborate enzyme complexes that can extend life in lower organisms and mediate the effects of caloric restriction. Caloric restriction, fasting, exercise induce the expression of sirtuins. Evolutionary biologists feel that it is an adaptation in times of famine for self-preservation of the organism. Sirtuins are NAD-consuming enzymes. NAD stands for nicotinamide adenine dinucleotide, and it is a coenzyme found in all cells. NAD levels increase in response to caloric restriction and, as stated, fasting and exercise, and decreases in normal human aging. Nicotinamide is a precursor of NAD, and supplementation with NAD precursors raises cellular NAD and sirtuin activity to compensate for loss due to aging. AMPK stands for adenosine monophosphate activated protein kinase. It is the second anti-aging gene discussed. Its physiologic role is that it inhibits anabolism and activates catabolism. For example, it decreases lipogenesis, decreases glycogenolysis, and as well inhibits mTOR activity. It activates glucose uptake, activates fatty acid oxidation, and autophagy is enhanced. AMPK is activated by cellular conditions that deplete cellular energy levels, like nutrient starvation, an increase in AMP to ATP level, indicative of a fasting or starvation state. Certain medications also are known to activate AMPK. Metformin specifically, salicylate, polyphenols, and ginsenosides. AMPK is known to inhibit tumor proliferation and progression and be intimately involved in the ability to limit the progression of aging in multiple lower life forms. mTOR stands for mechanistic target of rapamycin. It is our third anti-aging gene. Rapamycin was discovered on Easter Island in the 1970s, and currently it is an immunosuppressant, FDA approved for kidney transplants and certain cancers. Rapamycin binds to the mTOR protein complex and inhibits it. mTOR is a master regulator of metabolism and cell growth. It's responsible for skeletal muscle growth and wound healing. It's activated by insulin, glucose, and amino acids, usually indicative of a well-fed state. It is evolutionarily conserved and is a regulator of longevity across invertebrates and mammals. Caloric restriction extends lifespan by mTOR inhibition. Also, AMPK is activated by caloric restriction and also indirectly inhibits mTOR activity. Metformin is an activator of AMPK and inhibits mTOR directly. Aging drives the onset and progression of multiple disorders that are modulated by mTOR signaling. mTOR inhibition may have positive effects on multiple age-related pathologies in rodents and in some cases humans. Thus, slowing aging should increase both lifespan and health span. Health span referring to the period of life spent in relatively good health, free from chronic disease or disability. A word of caution about mTOR inhibition is that too much inhibition is potentially very harmful. It results in impaired muscle growth or response to exercise. It directly impairs wound healing, and GI manifestation with cataracts can occur. Niacinamide is an NAD precursor. The importance of niacinamide became evident with the discovery that pellagra is a niacinamide deficiency state in 1937. Pellagra is characterized by delirium, dementia, dermatitis, and eventually death. It had a high mortality, 40%, at around 1900, and its cause at that time was unknown. With the introduction of niacinamide and niacin by fortification of bread in 1941, pellagra was eradicated. However, these two B3 vitamins are often confused. They are distinctly different structurally and physiologically. The FDA classifies niacinamide as a food additive. The safety profile of niacinamide is well studied and safe. The potential toxicity is based on both animal and human studies, and at large doses, a transaminitis, hepatitis, and insulin resistance might develop. Both niacinamide and niacin were identified together at around the same time. However, niacin, because of its impressive effects on reducing cardiovascular risk and on lipid metabolism, is the more well-studied drug. Niacin is associated with significant liver toxicity and side effects at much lower doses. Early studies comparing both these medicines often confused the side effects of niacin with niacinamide. And in fact, many of these studies were mixtures of both these medications. Despite similarities in chemical structure, niacinamide and niacin have very different physiologic actions and clinical uses, and further should not be confused with nicotine. Niacinamide is also known as nicotinamide, and it has the classic carbonyl amine group. Niacin is also known as nicotinic acid, and it has the carbonyl hydroxyl group. While nicotine shares the pyridine ring, it has the pyrrolidine group, bound to a methyl group. The lethal dose 50 in mice is estimated to be 4.5 grams per kilogram when given orally. That's quite a large dose. High dose niacinamide should still, however, be considered as a drug with toxic potential at adult doses in excess of 3 grams per day. The recommended FDA daily dose is 20 milligrams daily. It is readily absorbed from the GI tract, and peak concentrations occur 1 hour after ingestion and has a high first-pass hepatic extraction. There's no evidence of oncogenicity or teratogenicity with this medication. Metformin was approved in the U.S. in 1995 for the treatment of diabetes mellitus type 2, and in 1958 in Europe. It has over 50 years of clinical experience. Metformin is inexpensive and safe in ameliorating the hyperglycemia and hyperinsulinemia of diabetes mellitus by reducing insulin levels and improved insulin site of action. It inhibits lipid synthesis, it mitigates hyperlipidemia, it reduces cellular levels of reactive oxygen species, and downregulates pro-inflammatory cytokines. Further, metformin has been shown to reduce the risk of cancer in patients with type 2 diabetes mellitus, improve survival in cancer patients in general, and may extend human health and lifespan. Its mechanism of action is activating one of the 3 anti-aging genes, AMPK, and as well is associated with reduced mTOR activity. Recommended daily dosage for the treatment of diabetes mellitus type 2 is 1 to 2 grams daily. The most common side effect is gastrointestinal, which is transient and avoided by gradual escalation of dosage. In high-dose metformin treatment, B12 deficiency with anemia can be seen, and with overdose, lactic acidosis has been described, which is a lethal event. It is contraindicated in severe renal and hepatic failure. Weight loss is associated with increased NAD and sirtuin expression. Metformin produced weight loss and delayed or prevented diabetes in the Diabetes Prevention Program trial. In this trial, individuals with diabetes mellitus were studied for 5 years, and metformin was demonstrated to be safe and well tolerated. In these individuals, it induced weight loss, and the weight loss was specific because it was associated with reductions in adipose mass with little change in lean tissue. Metformin's effects on energy metabolism appear to be parallel to those of physical exercise. Both stimulate the AMPK anti-aging gene. In this cohort of people studied over 2 years, on average 3.5 kilograms of weight loss was identified. Also, nicotinamide has been shown to aid in weight loss in mice, however not in human beings. Weight loss with metformin and nicotinamide. Exercise is able to reduce hyperglycemia, suppress glucose synthesis, and increase the metabolism of fatty acids. Combination therapy with both metformin and niacinamide may act like an exercise mimetic and as well a calorie restriction mimetic. The degree of weight loss noted in this study with both metformin and niacinamide, however, is not described in the medical literature and may be synergistic. Any risks with the use of metformin and niacinamide? Well, both drugs appear to be well tolerated and have a very predictable risk-to-benefit ratio. Some patient populations would be intolerant of these medications, secondary to the development of myopathy, hepatitis, or gastrointestinal side effects. I myself was healthy at the onset of this trial, and my overall health at 23 months remains excellent. I have no active medical problems at this time, and no significant adverse effects or toxicity have been identified as of yet. The effects of metformin and niacinamide take months before any changes are realized, which suggests that at a molecular level, DNA must be altered in an epigenetic fashion. Metformin and niacinamide appear synergistic, raising the possibility of future combination therapies to slow the aging process. The aversion to glucose that I described is novel and is not described in the medical literature. Many aspects of the aging process phenotypically have been slowed or ameliorated by these treatments, I would argue. I started these treatments at the age of 50 with no expectations and a very healthy skepticism. I was pleasantly surprised. It really is still unknown if these treatments will affect health span or lifespan. Questions. Did I really reverse aging, rejuvenation? Did I slow down the rate of age-related damage? Did I just lose a lot of weight, but I'm still biologically 52 years old? Does this treatment result in any protective effect in the development of age-related disease? I would argue there is some truth to all of the above questions. And I would ask, when should these treatments be initiated? In a 30-year-old, 40-year-old, 50-year-old? Really unknown at this time. Medications that delay the aging process is a healthcare imperative, and if implemented on a public health scale, would change the demographics of age-related illness, cost expenditures, and improve the quality of life in our middle-age and geriatric populations. These treatments should be implemented early, prior to the development of age-related comorbidities, given the time required to demonstrate clinical effectiveness. Many aspects of the aging process are irreversible once established, so the dictum of clinical medicine is that it is preferable to prevent the onset of damage than treat it once it's established. It can be argued that the gift of good health constitutes one of the most precious commodities in this world. It is one of the main determinants of happiness, contentment, and generalized well-being. Good health allows the individual to start over after failure and continue to grow professionally and personally to achieve contentment and self-realization. Combination therapy for rejuvenation and decreasing the rate of age-related damage is no different than chemotherapy, potentially very toxic, but at the same time restorative. It must be done with the utmost attention to detail and the highest level of medical surveillance. Cavalier attempts to replicate this study outside of medical surveillance is a recipe for disaster. The viewer might be both skeptical and cynical that this study of one person has any medical validity. I would argue that when all is said and done, I would far prefer to be the person on the right than the left. And I truly believe that metformin and niacinamide both helped me get there. Thank you for your attention, and if you enjoyed this presentation, please post a comment.